Allah yamasikum bil khair. Our first speaker for the session is going to be Professor Roberto Ferrari from Italy. Professor Roberto, please.
To the Jordan Cardiac Society, for me is really a big pleasure to be here, thanks to Jamal, to Ali, to many, many friends. Today I will be talking about artificial intelligence, but I will not touch the use of artificial intelligence in cardiology. This will be a general talk. And I will try to tell you where and how we got there, the light and shadows, there are many shadows, and the doubts. I'm sure that you remember this very famous film, and this was really the beginning of artificial intelligence. Because in 1950, Alan Turing, and the film was, by the way, The Imitation Game, Alan Turing asked himself, can a machine think? And then to assess this question, he proposed a very famous test, which is called the Turing test, which says machines are intelligent if they engage a written conversation of any subject indistinguishably from humans. That was in 1950. Thereafter, little happened. But you may ask yourself, why this test? Well, think carefully. I'm talking to you. I am putting one word after the other in a very consensus, in a very intelligent manner. Imagine what is happening here to decide each word one after the other. And really, expression or language is the capacity to logically arrange words which distinguish us from animals. And we call ourselves Homo sapiens. For a machine, however, it is very difficult to understand the word's meaning. Please turn right, or you are right. You understand the meaning of right, but not a machine. Because you understand it, because you know the context, because you put these sentences in the so-called knowledge of the word, knowledge of what you are talking about. And it is the context and the knowledge of the word which separates human intelligence from mechanical processing. You will see how important is all of this. Thereafter, very little happened. In 1956, John McCarthy coined the wording artificial intelligence, and he said, I will provide an intelligent machine in 2 months. It took much longer. Then we had Siri and Elisa. But they are responding to questions. They do not dialogue with you. And they work like a Swiss knife. They have a layer of information. You ask for a restaurant, they go there, they look all the restaurants, and they pick up the one that you asking for. Then in 1997, Deep Blue defeated at chess Kasparov, which was the world champion. So for the first time, an artificial intelligence was better than the world champion. And later, DeepMind defeated at Go. Go is a very complex play from China, and again defeated another champion. But the revolution happened in 2017. because these two gentlemen pioneered an algorithmic, and they call it the transformer. They were working for Google, and they got the Nobel Prize. And this algorithm trains a machine in seconds and not in months, process information very quickly, and analyze the relationship between the word of a sentence simultaneously and not any longer sequentially. And how they work, how this algorithm work, it absorbs all the offered context, it analyzes all the information simultaneously and not step by step. Then if you have a sentence, determines the connection between the word and combine this information with the context in multiple layers. It's like a big building, and the output goes to the next floor, get next and further connection, and next floor, and next floor. And they do that, for instance, for ChatGPT 86 times, and do it in seconds to generate the response. So it's not just being faster, but it is fundamentally different. How they did that? Simply they took a massive database of images to train the transformer, and they found that the transformer recognized the images better than humans. And by the way, they sold their startup for $44 million. Then, and this is very important, OpenAI, which is a biotech company, fed 7,000 books into a generic language model and created GPT, Generative Pre-trained Transformer. And GPT, using this knowledge of the world, these 7,000 books, was able to identify missing words in a sentence. They, on purpose, in big sentence, they took out a lot of words, and GPT did it very quickly, very precisely. And the paradox is that we do not know how it works. Thereafter, in March 2022, the first chat is born. You probably do not know about this. And the chat was called Lambda, and the inventor, Lemoine, did not put it into the market because he was afraid of the public reaction. He was a pastor, he was a religious person. And you know why he was afraid? Because he asked to the machine, how do you spend your free time? And the machine said, with friends and family. But the machine does not have friends and family. What he did, he put it together in order a statistical answer in order to please him. And he said, oh my God, this machine can produce all of this. What will happen in the public? But in November 2022, OpenAI had no hesitation and launched ChatGPT. And in 2 months, 100 million of users were registered. And then many competitors followed. Claude, Copilot, Bard, you name it, up to DeepSeek, which is from China, as you know. And there was an escalation in the words which were given to the chat. Look, GPT-2, 50,000 words. GPT-3, 10 billions. DeepMind, 1.4 trillions. Palm, 3.6 trillions. And today, we are running out of knowledge to provide to the machine. But not only quantity, also speed. Look at this. Do you know how long it took to have 50 million users when the first automobile was provided in England. It took 82 years. For the electricity, to have 50 million of users, it took 60 years. For the landline phone, 40 years. For the smartphone, 12 years. For YouTube, 4 years. For ChatGPT, we do not know, because we couldn't make the photograph of 50 millions, because it was so fast that in 2 months it reached 100 millions of users. So this is very important, the speed of acquisition of all this technology. And at the moment, we do not know how many people are using ChatGPT. It's not made available because of the antitrust. It is estimated 700 millions. Okay, these are the lights. Let's try to see the shadow. First of all, the data quality, because quantity does not mean quality. There are millions of hours from books, newspaper, film, everything that you digitalize. Remember this. Everything that you digitalize in YouTube, WhatsApp, Facebook, whatever, is collected, not by Google, but is collected from a specialized startup that then sells all this data to the big biotech. And the quality is only in books, is only in review articles, in journals. So the content very often is diluted by low quality materials. There is always copyright violation. There are synthetic data, false data, which are just put together by low-cost operators. And there are risks of escalation from very simple errors. A classical error in the automatic driving, the car was able to recognize a bicycle, but was not thought that a bicycle could be taken by a human being, and that human being has been killed. This is a little thing, and there are more than 132 persons that has been killed by testing the automatic driving. But there are very complex catastrophes, I'm afraid, when we are talking about military use of the AIE. And nearby here, they are using it. The US Defense Department alone spent $1,675 billion in AI in 2023. Ships, drones, submarine, aircraft, all operate autonomously. Theoretically, this should be for surveillance, but they can be weaponized. They are already weaponized. And the question is, does military AI promote peace, deterrence, or proliferate war? But there is more. Because, you see, this link between war and technology may be a very dangerous marriage. The digital warfare is not new. Even Alan Turing worked helping us to win the World War II, because he discovered the codex that the Germans were using. Internet was created for military purpose. But what is new is an actual critical problem, because technology is no longer produced by a nation, is no longer produced by a status. It is developed by private companies who are also control all the data and the complex data infrastructure of a battlefield. Now, when you purchase, for instance, a tank, you purchase a piece of iron. You can see the tank. When you purchase a technology, you purchase a software license, but you do not own it. You do not control this technology. I give you an example. When President Biden requested Elon Musk to deactivate Starlink, it caused an enormous problem for Ukraine, Because the war now is all the technology, but the national security now depends on private corporate. You have to think about that, because it's not an easy statement. Now, a reliability issue. The artificial intelligence doesn't distinguish right from wrong. It never questions its response, which often lacks source citation. Although I have to say nowadays they are becoming better. Statistical probabilities may create hallucination. Despite filters to prevent criminal or illegal output, system can be easily bypassed. False data can enter it for cyber attack or to influence elections. Data can be omitted. This is what is happening in China all the time. Look at this case. The KGB operates at least 140 websites producing over 10,000, deliberately, 10,000 fake news which are not targeting humans but machine. And look how it does work. The same simple story is repeated multiple times with tiny little changes. The machine acquires all these stories without human understanding. Because when we get something, we rely on our experience, on historical context, and we evaluate this information. But the AI breaks down the sentence mechanically. If the sentence is Azov battalion burn Trump's effigy, the machine learns a statistical association between Azov and Trump immediately. And that goes into his memory, and it may come up later on. So data poisoning corrupts AI training, embedding false association into the machine learning system. And then a power is born with the AI, which is the power of data. AI influences over 4 billion people. Imagine, 4 billion of us are connected with artificial intelligence. Algorithms are trained to generate the most probable word combination to satisfy you, not necessarily to be the right one. AI lacks moral judgment. It cannot distinguish right from wrong. It will respond to any query. And this is okay if we are consumer. Maybe we are purchasing something that we don't need. But sometimes AI can influence political votes. We had the example in Romania with TikTok election interference. AI can influence mental health, especially of the young people. OpenAIM has been sanctioned for more than 1,000 suicide induction because people are depressed, and if you are depressed and you start to say, I want to kill myself, the AI can really help you to do so. Also, we are deprived of our freedom. And our freedom is replaced by a sort of algorithmic guidance. There are hundreds of Chinese, and now I've been told also by US wearable sensors which are able to track your eye movement, facial expression, walking style, neural activities, to allow a constant biometric monitoring. We are living in a sort of a transparent bubble which is spying ourselves. The social impact of this follows different trajectories. In the Western world, it's threatening democracy. In China, it's consolidating authoritarianism. But where are the rules? Well, that is the problem. Because in US, there is no regulation. In US, they think that science and AI should not be limited. In China, there are robust rules, but they are designed for national strategic objective and social stability. And in Europe, Europe is the only one which has the IE and Digital Act, which prioritize citizen rights, democracy, and environmental values. And this act is based on different risks. And this is the problem. And this explains what is happening right now. Non-compliance carries penalty up to 6 to 10% of global annual revenue. This is what the Americans do not like at all. This is the reason why Trump is now a little bit against Europe, because all these big tech, they don't like to pay these penalties. And what about the hidden environmental cost? When you think about IE, I know I have a little bit longer. When you think about artificial intelligence, you think something immaterial, don't you? If I'm asking you, what is it? It's immaterial, but it's not. Because computing infrastructures includes computer, data centers, submarine cables, microchips, rare minerals. Without all of this, you cannot have an artificial intelligence. The daily electricity needs equals Japan's entire electricity consumption. The 44 billion electronic device uses 20% of the global energy, and not to talk about CO2. The cost of just training a simple machine consumes the energy of 33,000 US families. That is the reason why Trump needs to build mega gas-fired drill, baby drill, he said, in order to support the energy for the AIE. And companies are initiating a substantial measure to avoid all this growing consumption. Not to mention about the water, because majority of the centers are under the Arctic Sea in order to reduce the amount of water. And then the IE oligarchy. This is another big problem, because the US biotechnology from Silicon Valley dominates 7% of the global market capitalization. I call them the owners of the world. We are talking about $11,350 billion. Microsoft and Apple alone exceed the GDP of France and Italy. OpenAI's aim to provide trillions to generate a general artificial intelligence. Listen to this. The value of the 12 big companies is $25 trillion. The value of the old world gold is exactly between 25 and 27 trillions. The capitalization of the stock market of London, Paris, Frankfurt, Madrid, Milan, $16 trillion. We are lucky that these companies don't argue each other, because if they put together, they can buy the world. That is why I call them the owners of the world. 12 companies control lives and attention of 4 billion people. This platform observes us and our behaviors through a circuit window. Their digital system handles essential public function while simultaneous learning. We today cannot do without them. And their wealth and power are unprecedented. They can create money. They can build armaments, as I told you. They can influence politics. They can determine their own taxation. This is a techno-feudalism, and we are the 4 millions of vassals. Now, there is more, because recently, and you experienced that, the Silicon Valley power has migrated to Washington. And, you know, all this, the owners of this big tech were present at the inauguration of Mr. Trump, and created an unprecedented fusion of technological and political power that believes innovation should not be limited by ethical or regulatory rules. And they are developing a sort of religion. And the motivation is indeed economic, but the underlying project is anthropological, with a techno-utopic vision where humanity will transcend its biological limitation. Listen to this. Elon Musk advocates selective human reproduction based on intelligence metrics, doesn't he? He says only intelligent people should procreate. Neuralink aims to enhance the human brain with artificial intelligence. He wants to insert the chips in order to become much faster. Sam Altman consider post-euthanasia...
Professor Ferrari, we are 5 minutes over the time.
If you want, I can finish, but do you want me to finish here? Okay. I try to go very fast, and he wants to have his brain frozen, put the chips into it, and once the chips of Elon Musk will be ready, to reinsert into his brain in a synthetic body and potentially live there. Let's go faster. And we can even, considerations. I'm approaching the end. 7 hours after the Transformers, AI already encompasses human knowledge in many areas and acts autonomously. Since we don't understand how artificial intelligence thinks, can we ever control it? This was the critical question of Turing, Hinton, and Lemoyne. And I asked the question to ChatGPT and to DeepSeek. You do it. You can do it. ChatGPT said, I can pose a threat to privacy, security, and employment by automating jobs, manipulating information. Without regulation, I can apply bias discrimination and evade human control. DeepSeek said, the risks include discriminatory bias, invasive surveillance, unemployment due to technology, manipulation, fake news, and ethical opaque decision. Global regulation and human oversights are needed to avoid this risk. There are 200 scientists who are assigned some red line that the artificial intelligence should never cross. And you may ask, why sciences? Is not artificial intelligence science? Yes, it is science, but a particular science, because the research are done in private laboratories. The results are often become industrial secret, and the science become non-transparent and obedient to specific corporate interest. And that's happened also to the nuclear bomb or to the DNA modification. Those who invented the nuclear power then regretted, and so it is very important to oversight all of this. The real danger is that AI represents AI that we do not know if we will be able to understand and control it. Don't take me wrong. I believe that artificial intelligence represents the greatest discovery of our time, and will undoubtedly help humanity and help cardiology, and you are very well, you are doing very well to establish a group related to AI. But AI lacks cognitive activities, lacks will, desire, impulse, emotion, feeling, which are all human gifts. As AI is the result of human teaching, human control, and is intended for human users, and it has to remain with human. However, it creates alternative reasoning, different sometimes, and sometimes superior to the human thought. So I'm asking myself, who am I? And you should ask yourself, who are you really? Are we so intelligent as we think? What is that make us intelligent and different from an artificial intelligence? Can we really call ourselves Homo sapiens? Can a machine sapiens exist? Will transhumanism, if we never exist, improve our life? I do not know, but I know that we have a soul and a spirit, and we need to preserve it. I finished, just 2 slides. No, just 2 slides. Come on. But how? This is the problem. How? AI is so friendly and easy to use that engage all of us. We need education. We spend more time training people to use a machine than teaching them how the machine actually works. And this is a particular concern for children and for the next generation. We teach our child how to cross the street safely. But when it comes to using iPhones or computers, at least in my country, we say they know much more than us. That is terribly strong. We must educate us, the next generation, not to use technology, but to understand, to question, and to control it. And this is the last slide. AI must be considered a resource to be directed and not a power to be suffered. We need to know the light and the shadow of this potent instrument. And this is the main reason why now I speak more about AI than about heart failure and ischemic heart disease, which was my really topic, because the stakes are too high and the implication too far-reaching to remain silent. And please provide this information to everybody. Thank you very much. Thank you. I'm sorry for speaking long.
Thank you, Professor Ferrari.
Okay, thank you, Professor Ferrari. Thank you, my friends. Please allow me to present a token appreciation on behalf of Jordan Cardiac Society to Professor Ferrari. Professor Ferrari has been a valued and strong supporter of Jordan Cardiac Society, hosting several Jordanian cardiologists for hands-on training in human heart simulation and fetal echocardiography. We deeply value Professor Ferrari's enduring friendship and commitment to advancing cardiac education and excellence in Jordan. Thank you all.
Our next speaker for this afternoon is Dr. Yousef Zreikat, who is one of our primo pediatric cardiac surgeons. He will talk to us about switching gears, transposition of the great arteries, surgical innovation.
Professor Roberto, I wish that we can use this AI in the congenital heart surgery in the future. Good afternoon, ladies and gentlemen. I thank the organizers for the invitation. My presentation today is the surgical innovations in transpositions of great arteries. It will include, my presentation will include the overview about the transposition, diagnosis, management, and the way how we do it, and some videos. The whole picture of the transposition is discordance between the atria, the ventricle, and the great vessels. That's why they are divided into two categories. If we look at the first slide on the left side, you can see the normal flow in a line between the atria, right ventricle, and to the pulmonaries, to the lungs, to the LA, LV, aorta. In the detransposition, the discordance is at the level of the great vessels. As you can see, the patient get cyanosed because of blood is not mixed in a proper way. In the L transposition, the discordance is at the ventricular level. That's why they have atrioventricular discordance, ventriculoatrial discordance. In these patients, in the future, they don't get cyanosed, and so they are diagnosed late in life. My talk is about the detransposition. As we can see from this slide, the flow in the normal heart is a sequential. The RA, RV, PA, then to the LA, LV, aorta. In the transposition, RA to RV to aorta, then to RA. It goes into one cycle. And then from LV to PA to LA to LV, this is another cycle. So they are parallel cycles together. And that's why the patient gets cyanosed. The only way these patients are going to live if they have a mixture either at the level of the PDA, great vessels, or at the level of this ventricular septum or the ASD. The etiology of the transpositions, in general, they are unknown, but presumed to be multifactorial. And there is a common notice that they are in the, mainly in the infants of diabetic mothers. Now, the incidence of transposition in general, between 5 to 7%. If we look at the Jordanians population, around 10 millions, 10 millions, they have a number of births per year, around 180 Jordanians. The non-Jordanians are around 10,000. The congenital heart surgery incidence is between 5 to 6 per 1,000. If this reflected to numbers, there will be like 400 births with congenital heart surgery per year in Jordan. And since the transposition constitute 5 to 7%, we are talking about 20 to 28 and even 30 child per year in Jordan with the detransposition. The complication, if not treated, they go with the congestive heart failure, arrhythmias, and they might go into Eisenmenger syndrome. Diagnosis could be prenatal, and if the pregnant woman got a chance to go to major hospital, but some of them, they go and they are living in remote areas and they not get a chance to be prenatally diagnosed. And in a prenatal diagnosis, the typical time is between 18 to 22 weeks of gestation because all the structure can be sufficiently seen. Otherwise, in high-risk patients, you can look at them earlier. And these are the intrafetal echo. You can see the LV and the PA around. Not sure why the cursor. Okay, post-delivery, consequently, we go for history, chest X-ray, echo, and cardiac catheterization. They usually present with cyanosis. They are the most common congenital heart surgery with the cyanosis. They might be tachypneic, tachycardic, diaphoresis with if they lived longer, will have failure to gain weight. Chest X-ray, they look like egg in a string. I don't know how he thought about it, but it looks like egg in a string. Now, medical treatment, management, start with prostaglandins, and these are usually to dilate the PDA and keep it patent. And they might need antibiotics if they got infection, IV fluids, bicarb if they are acidotic. And if the doses of the prostaglandin are high, they might go to mechanical ventilation. Another PCI among the cardiologists, they can do the Rashkin balloon septictomy or septostomy, sorry, where they pop off the interarterial septum to increase the mixture between the two chambers. Surgical management includes in the arterial switch, we correct them in two ways, either ascending procedure or master procedure. In both ways, we buffle the superior inferior vena cava non-oxygenated blood to the left side, to the left ventricle, that is pumped to the lung, and the pulmonary blood flow goes over the buffle into the right ventricle, into the aorta. And in the Rastelli type, we make a conduit. After the closure of the VSD, we make a conduit between the right ventricle and the pulmonary artery. In the arterial switch procedure that is described by Jatan, where the major vessels are divided and they are transposed, and coronaries are translocated into the new aorta. Now, all the coronary problems in the switches are summarized in this slide, where 65% are normal, talking about 13%, the CERC comes from the RCA, and others single, either RCA or LCA, they come in a percentage like 1-2%, and the most difficult one where they are intramural, RCA or LCA. All these categories can be solved surgically by three ways. Either by punching the new aorta and reimplant the coronaries, or enlarge it using a trap door, especially if there was a deficiency in the button of the coronaries, or make a horseshoe, which is mostly used nowadays, that can reduce even the size of the new aorta in the procedure. Our technique, after we give heparin, we start a cardiopulmonary bypass on one cannula. And actually this makes us think more in making the incision smaller and more space for a procedure. And you can reduce the time of surgery, actually, and less injurious to the cavity, superior and inferior, in case of patients having low birth weight. After initiation of a cardiopulmonary bypass, we go deep hypothermia, reaching around 20. During this procedure, we start dividing the BDA. BDA is not ligated, it is divided into two parts, so that Lecombe procedure after that is done, and translocation of the buttons into the new aorta. Now, once we reach the deep hypothermia, we start a closure of the intracardiac defects, like ASD, simple closure. VSD could be plagiated sutures or using a patch, and this wouldn't take a long time. After that, we come up on bypass, taking care of the temperature. We stop the AC, we initiate heating blankets and Perhigers, and we resume ventilation early so that the temperature will not be dispersed. Continue heating till 38 degrees centigrade for around 5 to 10 minutes so that the patient will keep his temperature fixed. And we complete the rest of the procedure while we are coming up on the temperature. We don't forget that to keep the incubator nearby in the OR so that the patient will be transferred in a good position. I'm describing a patient from Algeria, came 1 month ago, and we have done it. He's 50 years old with VSD and ASD. VSD was huge with saturation 69. And you can see here, this should be with sound. I'm not sure why it's not with the sound. You can see the anteroposterior relationship of the pulmonary and the aorta. At the same time, you can see the VSD here and the ASD in this position. After dividing the aorta, we look for the buttons and we try to take them out for implantation. In this case, we started with the right. As usually, we start with the right. And we immobilize it. Next step in this case, we found that the VSD can be closed, as you can see, can be closed. This is the VSD, can be seen from the pulmonary side. So we decided to close it by a big patch. Preserving the pulmonary valves. Okay, after that, sorry for the inconvenience. This video doesn't play. Anyway, we closed the end of the patch, as you can see from both pledges here. We close it away from the valve so that we do not destruct the pulmonary valve. And after that, we'll take the button of the left and re-implant it into the new aorta. On re-implantation, it's supposed to be with the sound. I don't know why the sound is not coming up. And in these two slides, we complete the whole procedure by using a pericardial patch, sewing it around the defect in the neopulmonary. The complications post arterial switch could be coronary problem due to shortening of the coronaries or twisting, or obstruction in the RVOT, or incompetence in the valve because they are so exposed in the procedure. Actually, we have done in the Royal Medical Services, over the last 10 years, we have done 250 cases with a cross clamp of reaching between 50 to 65, and pump time were between 75 to 95, and mortality was 4%, but the study was not released till now. Overall mortality in arterial switch reaches 5% all over the world. In the atrial switch, long-term morbidity associated with systemic right ventricular dilatation and tricuspid valve regurg beside the arrhythmias. And all these procedure and this technique needs to be in a long learning curve to be accomplished in a correct way. Thank you.
Thank you, Dr. Yousef. Thank you, Dr. Yousef. Our next speaker is Alessandro. He is from Milan, and his talk will be about the surgical management of hypoplastic left heart.
Then,
some rearrangement in the program, so.
خلاص.
اوكي ممكن مش قادرين نشبكهم معاه. Our next speaker will be Dr. Giuseppe Isgrò. He is a pediatric cardiac surgeon and we will talk about the post-operative treatment.
Hello, Dr. Isgrò. Can you please start?
Hello, can you hear me?
Yes, yes.
Oh, it's just my time or?
It's your time, go ahead, sir.
It's your time.
Okay, okay. Well, I try to share my. Okay. Now you can see my screen. Please.
Yes, doctor, go ahead, please.
Okay, okay, I can do. Good afternoon, everybody. It's my pleasure to attend this meeting. Unfortunately, I cannot attend directly there, but because I'm actually I'm in Cairo for another conference and surgical workshop. Anyway, I'm Yousef Zreikat. I'm the head in congenital intensive care in San Donato Hospital, and my topic now is just to share with you the post-op management of newborn or any kind of congenital patient with congenital heart disease. We know that the post-op is a very delicate moment and needs to qualified people to work in this field. This is the reason why for many, for two different approaches, for example, the society, sorry, it's not moving, okay, the European Society of Cardiology, the ACS and the ATC proposed guidelines. These two guidelines regarding the patient with transposition ZreikatPrivate with intraventricular and that, as we will see after, guidelines for hyperplastic ventricle is an important source for treating this population, starting from pregnancy to adult life. And what is particularly interesting for us is some recommendation in prenatal management in NICU, for example, to start you normally I this setting, avoidance intubation of infants only because they have worked only GPA, not individualized for the pathology, for the condition of the patient, but only for this. And other recommendation such the primary breech operation that should be performed in the first 3 days to 3 weeks of life in a normal way, in a safe condition, or also in until 60 days of life with ECMO breakup is my field of interest, important field of interest, is the postdoc. And in the postdoc, we have some recommendation in class 1C. For example, the checklist is okay, but what is recommended is to use, for example, annual dilators, extremely important to manage this particular population. According or in addition to other drugs such as noradrenaline, adrenaline, or dopamine. Today, during in cardiac surgery, many surgeries is still the vitamin, but the vitamin is not a good choice in this population. We prefer to manage our patient with two drugs. One of these is usually Milan, it's an anodilator, phosphodiesterase 3 inhibitor, with adrenaline or dopamine. Of course, you have to use ECLS, any kind of ECMO support, in case of need to increase the dosage of adrenaline. And this is class 1C, the use of Miriam together with a low dose of heparin or epinephrine. So it is extremely important. In my opinion, Miriam is one of the drugs that you cannot throw away from money back. The other guidelines regard the management of neonates with hypoplastic Dakar syndrome. Well, is a particular population with many recommendations. Again, it's important to do a strict monitoring of this population with standard SEO monitoring plus the venous saturation near infrared and other. In our center, we do other monitoring that we will see. Again, what is important to do with these children is to use artery or any kind of vasodilator to reduce the systemic vascular resistances to optimize the outcome. And important, extremely important, to is the management of the postop of these children with sharp blood calculation. The ideal EQS, as you can see here from the formula, is 1. So you have to move around this number, around this balance calculation. Extremely important to manage in the correct way these children. Otherwise, if you increase PQS, you go on towards the pulmonary overflow and low cardiac output, or on the other hand, on the other side, to extremely separated patient and not with a really good cardiac output. There are a lot of clinical variables that we can take into account or we use: systemic arterial pressure, diastolic, systolic arterial pressure, diastolic, mean arterial pressure, oxygen saturation, central venous pressure, and blood lactates. Well, blood lactates correlates very well with ICU stay. Higher are the lactates, and anytime lower is the ICU stay. This is extremely important as monitoring the venous saturation, and we will see. Just to understand how is important the use of Mirinone, this group of anesthesiologists from Japan published recently this paper in which they put in they groups before and after introducing the Miranon. And what they found is that the group treated with Miranon had a better outcome and a better survival over 1 year. So one other, we have a lot of literature regarding this in this moment, but this is extremely important regarding the use of Miranon. Why is? Because mixed venous saturation and blood lactates can be manipulated by use of vasoactive drugs, in particular Miranon or adrenaline or noradrenaline, depends on the situation. From the group of Milwaukee, the group of Hoffman and Giuseppe, some years ago they published this paper about the mixed venous saturation monitoring after stage 1 palliation for left heart syndrome. And they had a lot of complications in this group, from arrhythmia to ECMO to dialysis and death. And what they found is that those patients that had complicated survival, survival with complication or early death had higher level of venous separation. Very important is to consider the first 18 hours. If in the post-period time, in the first 18 hours, you have a good rise in venous saturation with respect to basal level, you are in a good condition with respect to those patients that had early death without moving too much, increasing too much the venous saturation. That means that venous saturation is correlated to general condition, public output, and at the end with the mortality at the end. They put a cutoff on this group that is 55%, under which they observe more complication, early ECMO, any kind of ECMO, CPR, mortality at 30 days, and any mortality where all these complications higher in the group that had less due to less than 55% with this respect the other group. So our goal is to keep in this patient in the post-op an higher level of SpO2, more than 55% if it's possible. So we have to work in this. And in our institution, we published a paper regarding the combination of central venous oxygen saturation and blood lactate level during cardiopulmonary bypass. And we found a strong association with the outcome in pediatric cardiac population. What we found is that during cardiopulmonary bypass, if we had high lactate level or low level of venous saturation, this correlates both with major morbidity and mortality. And is important for us because the combination of continuous monitoring of central venous oxygen saturation and serial measurements of blood lactate during cardiopulmonary bypass is an index for major morbidity and mortality, of course, after cardiac operation. So we have to put any kind of management to preserve oxygen delivery during cardiopulmonary bypass. This may use the low values of central venous saturation and blood lactate level. And this is important because when I see the patient from OR and the first AEG that I do show lactate level high and venous saturation low, that means that in the operating room something happened or better was done perfectly the management in the operating room. And this starts during catheter bypass. So it's important that our perfusionists work well, our anesthesiologists work well just in the operating room to arrive in intensive care in the best condition for the patient. And hypoplastic or arterial Swedish operation patients suffer for this more than the other patients. So this is the reason why we created an algorithm based on SpO2. Of course, if you have a normal SpO2, this is for mainly for which operation with a normal heart in the end, but you can put it to 55 or more than 55 off if you have a single ventricle, for example. Anyway, you don't do nothing if you consider that is normal. If this is decreased, well, first you have to check the arterial circulation, and maybe you have to impact on the ventilator to provide ventilation, if the CO2 operative, regulate the lungs, and so on. If it's normal, maybe you are in a situation of increased extraction ratio, oxygen extraction ratio. So you have to check the cardiac output, of course, indirectly in our babies, using mainly the echo or other indirect parameters. And if the cardiac output is normal, check for hemoglobin. If hemoglobin is low, transfuse the patient. We used to put the hemoglobin level more than 10 in our babies, in our newborn. That means that we work in between 10 and 15, and an atopic level more or less 45%. If the hemoglobin level is normal, maybe our patient is not well sedated in intensive care, so we have to check the depth of anesthesia and to sedate better patient. Going back to the cardiac output, if the cardiac output is low, we have to check the preload. If the preload is low, we have to give fluids to our patients. Normal fluids, free fluids, I mean normal saline, range lactate, and so on. If the preload is normal, you have to consider to increase or put some antibiotics just to demand the patient. This is our output. Of course, we monitor the patient with near-infrared spectroscopy, the NIRS, that is used all over the world as a simple tool. We have just for monitoring the brain and the flank, just to understand if our patient is in a stable condition. But what is important to understand is that regional oxygen saturation measured by NIRS is not precisely predict the central venous saturation, and should not be considered as a substitute. That means that you can manage your patient with near-infrared. That is a very good trend monitor, but again, venous saturation is a number on which you actually you can work. 2 minutes left, so I spent these 2 minutes showing this is a patient, a newborn in our intensive care. You see on the left the ECMO support. On the right, you have monitor, and on the back, the ventilator with the normal monitoring, near-infrared venous saturation, continuously, normal parameters, but it's important to understand what we are doing now. We monitor our patient with continuous EEG monitoring. That is not only for the brain, for any kind of problem, like this is a normal patient with normal radiation. You see in the upper part there is the complete EEG waves, and the lower part there is the amplitude EEG. These are seizures, a movement like seizures. This is a bad patient because it was a cardiac arrest with a low cardiac output syndrome. And this is what we found in one patient. We published the report now. This patient had the monitoring in intensive care, and we closed the chest early in the morning on the left side of the screen. After some hours, we started with the slightest sign of low cardiac output syndrome. So we reduced the diuresis, low level of metabolic acidosis, lactate start to be increased, and so on. After some hours, we found that our patient started to be bad with the brain. That is, start to reduce the waves, the amplitude of the waves. There is no variability. So this was the decision to open the chest because the slightly sign of low cardiac output syndrome impact negatively on the brain. We opened the chest. After some hours, the brain became normal. So we closed the chest after 2 days without any kind of brain abnormalities. So I finish with some messages. First of all, it's important to consider the balance between the oxygen delivery and oxygen consumption in the post-op, and should be calculated as main strategy. SGO2 and lactate are the most important parameters to manage, extremely important, more than arterial pressure, more than other saturation, and so on. Anodilators is the first choice drug in combination, alone or in combination with low-dose positive inotropes. We do that for almost for all the patients. Avoid high-dose inotropes. If you have to increase the drugs, you have to stop, and start with any kind of support, mainly ECMO in this case for the newborn. We put a cutoff to 0.1 adrenaline, for example, to consider to start the ECMO support in our patients, especially neonates, especially plastic or switch operation. Brain monitoring should be used for all critical newborn, not only for management or preventing brain damage, but also to consider that the brain suffers before any kind of cardiovascular problem. Post-operative management, in my opinion, is a delicate step and requires a great deal of knowledge, especially we have to know the pathophysiology of cardiac disease and the pathophysiology of the correlated palliation or correction. This is important for us, for the nurses, just to understand what to do if this patient respects the other. Thank you very much. I finish.
The question will be at the end of the session. Our next speaker is Dr. Alessandro Varrica, and his talk will be the surgical management of hypoplastic left heart syndrome.
Dr. Alessandro.
Good morning, everybody. Do you see my... Do you see the presentation or not?
No, doctor. No. Yes. Yes. Perfect. No. Now open the presentation. Yes.
Now?
Now, yes. You can go ahead.
Okay. Thank you very much. Good morning, everybody. Thank you for the invitation. My name is Alessandro Varrica. I am a cerebral and somatic nerves, and the vesical catheter with the peripheral fluid. After opening the chest, we bring the autologous pericardium, harvesting, and fix it with glutarate 0.5%. And we isolate the ascending aorta, the aortic vessels, the pulmonary arteries, and the two arterioles. We do normally a fraction in the venous thrombus, left venous thrombus, that is important, not the deep fracture, because it's very important for the future procedure. And the second steps, after we isolate the brachial arterial thrombus, we put 1 milligram per kilo of heparin and put a C-clamp and connect with the AbuHaweeleh tube 3 millimeter or 3.5 millimeter, depending on the weight of the patients, 8 kilos, 3 millimeter for patients, 3 kilos or 3 kilos, then more, and 3.5 millimeter for patients more than 3.5 kilos. We do the anastomosis with choline-7-0, terminolateral anastomosis, and with this tube for us is important to perfusion to put the cardioplegia and obviously the perfusion with the CT. After this, we put the full heparin and cannulation, and we put inside the vertex tube the cannula, 8 French or 10 French, depending on the weight of the patients, and we interpose with the position of the lure between the arterial line and cannula, because in this lure we put inside a connection for the cardioplegia, because we put the cardioplegia through the aortic cannula when this is necessary. And we put every time the ductal cannulation, so either the nacara and then to the bathroom, and start CPB. After start the CPB, we close the pulmonary arteries, and we see if it's possible to close the ductus, so we see the pressure up and down, and we see if it's present the difference. If it's not coarctation, we close the duct, and we open the pulmonary arteries, and we start within for 50 minutes, and we arrive normally at 27 degrees. During cooling, if is present aortic adhesion, it's possible to do the atrioseptectomy, open the right atrium, remove the interarterial brain. It's possible to transect the pulmonary trunk below to the pulmonary arteries, and the autologous pericardial patch, we plant the autologous pericardial patch presently fixed with the glutarate at level of the pulmonary bifurcation. And through the pulmonary valve, we identify if we do the normal standard procedure, we identify the right vent of the site. When we do the ventriculotomy to connect the right ventricle to the pulmonary bifurcation. And after this, if we see the bifurcation with the pericardial patch, with the right angle we go through the pulmonary valve, we identify the position, the right ventricle, obviously not near to the coronary arteries. And when we are ready to the temperature, another important point during cooling, we dissect the descending aorta, and we divide the first 2 or 3 sets of intercostal branches to use the retractor, and it's very important to avoid the recurrent nerving. Well, this is the right angle, and we identify the best position for the ventriculotomy to use the right ventricle to pulmonary artery conduit. And when we arrive at 27 degrees, we close the left carotid artery, the left subclavian, clamp the aortic arch and innominate artery, stop the CPB, clamp the arterial line, and start with cardioplegia and we use every time the endocardioid. The heart is stopped, stop the cardioid, and we clamp the innominate artery below the vertex tube, and we close the aortic vessels, and we start with cerebral perfusion 20-50 millimeter cubic. When it is present, this is the first moment after a cardioplegic arrest, and if it is present with the shaft, the coarctation in the posterior part of the isthmus, we transect this part and we mobilize before with the sacrified first intercostal artery, and we mobilize the descending aorta. And posteriorly, we use the direct anastomosis between the descending aorta and the aortic arch. And after this, for reconstruct the double scale, we use every time the anastomosis between aorta to ascending aorta to pulmonary trunk with the 8-0 commissure. And after this, we reconstruct and we do the double scale anastomosis. When the ascending aorta is not very small, 2 or 3 millimeter, in presence of the aortic adhesion, it's possible that the technique is similar to double barrel, but normally we use the double scale class. For the double scale, obviously the best solution is the omnigraft, the pulmonary omnigraft, and we use the pulmonary trunk at the origin of the left pulmonary artery, because the anatomy, the curve is very similar to the aortic arch. Another option is the pericardial 3D patch, mobile patch, by hermetic procedure that is very good for the results in terms of reconstruction of the arch. But if we don't have the homograft, pulmonary homograft, or the 3D pericardial patch, it's possible to use the heterologous pericardial patch. We have this triangle, and we put the first point here in the upper part of the arch, the posterior for the posterior reconstruction, and the curve anteriorly to reconstruct the anterior part, and the basis of the triangle to reconstruct to suture around to the pulmonary. It's very important to connect, because it's important that we don't have the distortion of the coronary arteries. And the dimension of the patch, the diameter, the array is 3 centimeters. Two options: the normal classic with the shunt, and it's possible to use the same shunt that we use to the cerebral perfusion during the operation, or the normal side procedure to connect the right ventricle to the coronary ventricle. In our center, we use every time the normal side procedure, and we use the DAP technique. We put inside to the right ventricle in the first 3 rings inside the third level of the surface, external surface of the heart, and we put the 2 pulse rings around and fix it to the ring around the tube, and after we put to avoid the compression of the tube by the right ventricle muscles. And after we use we perform the distal anastomosis at the level of bifurcation with the Milanese. So 7-0. Normally we use a 5 millimeter reinforcement vertex tube. Rarely, if the patient is more than 15 days or the weight is superior to 5 kilos, but rarely we use 6 millimeter vertex tube. Another alternative is the hybrid approach, and we use this indication and this approach in patients with weight superior to 2.5 kilos, with mitral and aortic aplasia, with the restrictive ASD and other comorbidities. In this case, it's possible to, before surgery, we do the brushing by intervention cardiologist, and after open the chest, put the bilateral band at level of the right and the left, and the patients continue the infusion of prostaglandin, and after 1 week to put the stent in the uterus. It's not easy procedure, it's complex in terms of immediately is the problem that we see is not rare, that the stent inside the uterus is important in terms of obstruction of the aortic arch and retrograde coarctation and hypoperfusion of the coronary artery, because many times it's long, because it's not existing stent for the uterus for this type of patients. And the other problem for the future is the bilateral bending of these patients that is candidate to compound procedure at the bending and scar around the pulmonary arteries, increase the risk of distortion or the risk of stenosis of the pulmonary arteries. The hypoplastic left heart sign in terms of mortality is not low, is 5-50%. The early complication is coronary distortion and ischemia, out-of-valve insufficiency, pneumovalve, arrhythmia, or pulmonary artery stenosis. This is the Isgrò trial, and the mortality on the first stage is 6% and is 12% in the interstage mortality, because the risk of closure of the shunt of the Bassam Akasheh is high in this type of patients. But the reality is different, because if we see the mortality in the European Congenital Association, we see that the normal procedure, the overall patient's mortality 50 days is 23%, and the hospital mortality is 28%. In Europe, people, and in the other continent patients is 53%. We analyzed our experience in the last 6 years, and we see 41 patients. The age is 18 days. We see all the patients, because we accept 100% patients by Romania, by Egypt, Tunisia, Algeria, and obviously it's not easy to do this operation in the first 15 days, because the first week of 10 days is the best moment to do this type of operation, and it's not possible in these patients to do the rasting, because we have a restricted ASD, and obviously we see that these patients is not the best patients for this type of operation. But we use in 88% of patients non-Bassam, and 5%, 12% of the non-classic. Our hospital mortality is 22%, 9 mortality in hospital, and 4 in the stage mortality. In 25, performed the blend procedure, and 4 of these received amputation of the aortic arch for recommendation, 16%. For 2 patients, is not eligible for the compound procedure, because the condition of the anatomical condition, the acoustic insufficiency that mentioned on the pulmonary artery, are no good, and for this to increase the pulmonary saturation, we do axillary fistula between axillary artery and axillary vein, and increase the flow through the gland, and we see that increase the saturation 5-7% in terms of SO2, and 11 patients do the compound procedure with all patients, obviously with extension. In our center of patients with the normal procedure, go out to the operating room with the open chest, 3 drain, retrocardiac, right level, left level, and peritoneal drain for the not for the peritoneal dialysis, but only for the fluids. And it's not a problem that the patients go out with a 70, 75 saturation. It's not necessarily a hypersaturation, but we prefer that in the first 24 hours after surgery, it's important to evaluate the QS and not the QT. We prefer that we have a goal with 70, 75 saturation, a good flow in the systemic in the body, but no hypersaturation. We think that it's best, the best solution in the patient is better the patient's blue than gray. It's better desaturated than low cardiac. Then the clinical figure about history is very long. The normal procedure is only the first one step, but the way is very long. The third procedure is the second one, and the Coronary is the third. But the way after Coronary is long because the quality of life, the future of this type of patients is not easy, and the risk of transplantation is the double is about double risk respect to the other spontaneous that is not in origin apoplastic transplant. Thank you very much.
Thank you, sir. Now the next speaker and the last, Dr. Abdelfattah AbuHaweeleh. Dr. Abdelfattah is one of the most senior pediatric cardiologists in the private sector. He has a very good experience in the Royal Medical Services. He's going to talk about the anomalous origin of the coronary arteries with the incidence of death among these patients. Dr. Abdelfattah.
مسيكم بالخير جميعا وبشكرك دكتور يوسف دكتور مازن والاودينس my dear audience. In fact I would like to thank as well the organizing committee for allowing me to talk about a bit difficult topic, variable and sometimes debatable when to interfere. Next please. I have no disclosure, and as you know, congenital anomalies of the left of the coronary arteries have a global incidence of about 5.6%. Approximately 20% of all may have a potential risk of coronary ischemia, leading to myocardial infarction, arrhythmias, and sudden cardiac death. Incidence of coronary artery anomaly related sudden death is 0.6%. And regarding the guidelines, the classification for these anomalies, we have one anomalies of the origin and the course, and this involves arteries arising from wrong aortic sinus or following unusual pathways like interarterial, retroaortic, or peripulmonic. The second category is anomaly of the intrinsic anatomy. This includes within the vessel wall itself, such as myocardial bridging, where a segment dips into the heart muscles. And the third type, anomalies of termination, which means that one of the coronaries will terminate in abnormal location, like a coronary fistula draining into a heart chamber. And regarding the functional classification of the coronaries, it could be ostial atresia, ostial stenosis, alcaba, the fistulas, or muscle bridging. This is the functional classification for the coronaries anomaly. The previous one, it showed a fixed ischemia. This functional classification is an episodic. Sometimes it gives you an ischemia, sometimes an intermittent ischemia, like abnormal coronary artery origin with tangential origin, intramural course, myocardial bridging, spasm or a clot formation, coronary ectasia, mural or a clot, coronary fistula sometimes, mural or a clot. These are giving you episodic ischemia. Anomalies of the origin and course, sometimes we have absent of left main trunk. And it splits into the LAD and circ, and usually it occurs about 1%, more frequent with bicuspid aortic valve abnormalities. It has no clinical sequence, and coronary ostia are usually smaller than the left main. Anomalous location of coronary ostium within aortic root or rear proper aortic sinus. نحكي نحن دائما high take off of the coronaries. It could be high, it could be low, it could be at the level of the commissures. Anomalous location of the coronary ostia outside the normal aortic sinus. It could be from the right posterior aortic sinus. It could be from the LV, RV, PA, aortic arch, descending thoracic aorta, innominate artery, right carotid, bronchial artery, subclavian, and lastly, from the pulmonary artery. This is the anomalous location of coronary ostia outside the normal aortic sinus. Al-Kaaba. Al-Kaaba is quite common. We see it in pediatrics, where we have left coronary artery arises from the pulmonary artery, from the posterior facing sinus. It is present early after birth with anterolateral infarction and a slight retrograde flow from the left coronary to the PA. It depends on the size of the collaterals and from the size of the left coronary artery. 15% of patients, they have myocardial flow, can sustain myocardial function at rest or even during exercise. I will show you examples. In adult, they present with enlarged right coronary artery and collaterals and significant retrograde flow into the pulmonary artery. This is an example here. This is the pulmonary here, and this is the left coronary artery arising from the pulmonary. The CT angio. This is a very rare case, in fact, and it was our patient presented at the age of 14 years with Al-Kaaba and corrected TGA. This is here, the LV giving rise to the pulmonary, dilated pulmonary, and this is the left coronary artery. Very rare combination. And in fact, since the left ventricle is not the systemic one, I think the decision was at that time to go for medical therapy for this patient. The clinical features of Al-Kaaba, usually they present with acute discomfort precipitated by feeding. We call it feeding angina. Usually the babies, once they get feeding, giving a milk, they get calm and they get quiet. If they get irritable and get in pains, it means he got some sort of feeding angina. They present sometimes with congestive heart failure. At the age of 2 to 3 months, physical examination would show an congestive heart failure with mitral regurgitation, and the ECG shows Q wave in lead 1 AVL and precordial V4, V6. Older children and adults may be asymptomatic or have dyspnea or syncope on exertion. Sudden death is reported after exertion. Echo is very helpful. There's a clues in the echo showing the origin of left coronary passes to the pulmonary and enlarged the right coronary artery. Aortic root and CT angio is very helpful in diagnosing, as you saw the images. Treatment, sometimes they present with congestive heart failure early in life, and you can sacrifice the left coronary artery, you ligate it because of the large shunt, or direct reimplantation of the origin of left coronary artery into the aorta with a button BA around the origin. Dr. Yousef, I think, did some cases for us like this. Ligation of the origin of left coronary artery and constitution fluid through the subclavian, doing bypass for this patient, and Takayasu procedure, which means a aortopulmonary window is created as a tunnel fashioned that directs blood from the aorta to the left coronary artery. And I think we have done it as well. The other anomaly is the coronary ostium at the improper sinus, the RCA from the left anterior sinus, the LAD from the right, the circ from the right anterior, the left coronary artery from the right anterior sinus. In fact, the right coronary artery arising from abnormal sinus is 6 times more prevalent than the left one. And the left one, the left coronary artery, has a higher risk of sudden cardiac death. And the RCA from the left anterior sinus with anomalous course, this is the courses. It could be posterior AV groove, it could be retro-aortic between the aorta, and this is the most common type between the aorta and the pulmonary, interarterial, and it could be intraseptal, anterior to the pulmonary flow, posterior anterior interventricular groove. And these are the variation of the course. This is an example here. You see a CT angio showing the right coronary artery arising from the left coronary sinus. The other thing, the left coronary from the right anterior sinus with anomalous course, these are the variation. It could be between the aorta and pulmonary, anterior to the PA, retro-aortic, intraseptal, posterior AV groove, posterior anterior interventricular groove, and these are the combinations and the abnormalities. Management, if the patients are symptomatic, we go for surgical intervention, unroofing or reimplantation. If they are asymptomatic, if we can demonstrate an ischemia by stress test or perfusion SPECT scan, we have to repair. No demonstrable ischemia, watch and observe. The left coronary abnormality from the right, always we should repair, and we have guidelines for this. And this is a class 1 recommendation regarding the left coronary arising from right sinus. Revascularization is also recommended for interarterial anomalous origin of left regardless of the ischemia or symptoms. If we discover it, we have to repair it. Okay. Single coronary artery incidence is very rare. Single ostium with absence of an ostial is an opposite sinus. No other coronary artery from an ectopic side. It is associated, in fact, 40% with cardiac malformation like TGA, TOF, tricuspid coronary cameral fistula, and bicuspid aortic valve. And it's characterized by ostial dimple at the left or right aortic sinus terminates in a cord-like fibrous structure without a patent lumen. Proximally it's occluded. Usually we have collaterals. Stress testing demonstrates myocardial ischemia and seen in pulmonary atresia, a groove intact septum. Intramural course, and it is quite higher incidence, about 1%, and most commonly associated with ventricular hypertrophy. myocardial bridge or muscular bridge, coronary artery segment of variable lengths covered by myocardial fibers, angiographically recognition of systolic narrowing, and may also occur in ventricular aneurysm or pericardial fibrous band. I will discuss the management guidelines for these things, and I will go for coronary fistulas is a sizable communication between the coronary artery and cardiac cavity. And it could be in any segment of a systemic or pulmonary circulation. Fistulas from right coronary, left coronary, or infundibular artery to RV, pulmonary arteries, coronary sinus, all these are reported and present. Originate from the left coronary system is about 50 to 60%. Right coronary system, 30 to 40%, or both. Most fistulas, 90%, they terminate in the right side of the heart. And the complications of the fistulas, aneurysmal formation, intimal ulceration, medial degeneration, intimal rupture, atherosclerosis deposition, calcification, and side branch nutrient obstruction, or mural thrombus formation, sometimes coronary rupture. All these reported. Treatment, the amount of dilatation of the fistulous vessel is more relevant than fistula's flow. Symptoms and signs of myocardial ischemia, catheter-based or surgical intervention nowadays attain an early and the best, I think, management according to the anatomy, and we used coils, double umbrella, ambulatory plugs, all these were used. Reversibility of ectasia is consistently reported in pediatric age. I will show you an example now, and the optimal time, if there is no signs, is between 5th to 15th year of life. This is an example here of a huge right coronary fistula terminating into the RV. Sorry. Then we crossed the fistula, we did an occlusion test to demonstrate there is no ischemia after occlusion. Then we deployed a bladder plug for this patient, and as you see here, we have seen, sorry, the normal vessels branches of the is shown, and by the time this is the patient presented to us at the age of 3 years, and I did follow up for him a cath. It showed really a regression of the size of the fistulas. Now, just briefing and summarizing the guidelines and literature. Risk of sudden death probability with anomalous, only the origin of from the pulmonary trunk is considered a certain cause. The origin of left coronary artery from the opposite right sinus of Valsalva is considered as a highly probable cause of sudden death, and the remaining, the right coronary artery from the left or from the right or retroaortic course, take off, myocardial bridging, are considered as uncertain cause of sudden death. And the take-home messages are sudden cardiac death is associated with 4 risks: stent-like orifice, acute angle of take-off from the aorta, tangential origin, presence of aortic intramural coronary arteries, inter-arterial course between the aorta and pulmonary with demonstrable ischemia. Thank you very much. And this is usually, we see a bit from the coronaries but the rest is the capillaries and the arterioles. We couldn't see it and assess it. This image. Thank you.
Thank you, Dr. Abdelfattah. I think we are running out of time. Probably one question, and then you can grab a coffee break. تفضلي.
For coronary anomalous origin, CT angio is the better or the best modality of imaging. والسؤال الثاني بالabnormal origin of coronaries, you mentioned descending thoracic aorta. Usually once we do CT angio or aorta, we don't, maybe we miss it. How to find this? Or what is the modality best to not to miss that?
Before CT angio, usually we assess clinical signs and symptoms, the ECG findings. We do sometimes stress test, sometimes we do perfusion test, and if the CT was not convincing regarding the bridging or intramuscular course, we'll go for cardiac catheterization.
No, I mean origin of coronary artery from descending thoracic aorta. You mentioned
very rare.
Very rare.
In fact, I lost the angio. In fact, I had a patient with left coronary arising from the descending aorta.
But aortogram is the imaging we diagnose.
Usually, it is associated with complex anatomy. You know.
Yeah.
Usually, they have symptoms.
Okay. But we do aortogram to see it.
Of course, yeah.
Yeah. Okay. Thank you.
On the behalf of the audience, we thank our guests abroad for sharing us this session. And I think we are running out of time. By this now, we will end this session so that you can go coffee break and go for the next section. Thank you.
Thank you.